Within this blood vessel, glucose molecules have reached a state of heavy saturation, yet the surrounding tissue cells remain empty. This chronic state of hyperglycemia is the defining characteristic of diabetes mellitus. This elevated glucose level represents the final stage of a systemic failure in metabolic regulation. It arises from defective insulin secretion, defective insulin action, or a combination of both. These distinct cellular failures define the two primary pathways of the disease, type 1 and type 2 diabetes mellitus. Type 1 involves an absolute lack of insulin. It is an autoimmune condition where the body destroys its own insulin-producing cells, typically presenting in children and young adults following a genetic or viral trigger. Type 2 is characterized by peripheral insulin resistance paired with a relative insulin deficiency. While historically associated with aging, its clinical link to obesity and sedentary lifestyles has increased diagnoses among younger populations. Other variants, such as gestational diabetes during pregnancy or drug-induced diabetes from steroid use, also converge on this same hyperglycemic state. Effective treatment requires moving beyond the observation of high blood sugar to address the specific cellular mechanics driving the failure. Cellular glucose uptake depends entirely on insulin signaling to trigger the translocation of glucose transporters to the cell membrane. We analyze these primary failure architectures using this split-screen model. Left, a healthy pancreatic beta cell. Right, a peripheral tissue cell with insulin receptors. In type 1, a genetic or viral trigger causes an autoimmune response where T cells systematically destroy the beta cells. Consequently, insulin production drops to zero. Without this hormone, extracellular glucose accumulates while the tissue cell starves. To compensate, starving cells break down internal lipid stores, releasing ketone byproducts into the bloodstream and creating a severe ketoacidosis risk. In type 2, the initial failure is tissue-level insulin resistance. The pancreas produces insulin, but peripheral cell receptors fail to respond. Because signaling is interrupted at the receptor, glucose cannot enter the cell and accumulates in the bloodstream. The pancreas attempts to compensate by increasing insulin output to overcome the resistance, eventually leading to beta cell exhaustion and gradual dysfunction. Because some insulin remains circulating in type 2, the massive lipid breakdown seen in type 1 is suppressed. Ketoacidosis is rare, though extreme hyperglycemia can lead to a dangerous hyperosmolar state. In both pathways, the cell starves while the blood becomes saturated with glucose. The difference lies in the source of the failure, a total absence of the signaling hormone versus a failure of the target tissues to respond to it. These cellular failures translate into the classic clinical triad of symptoms known as the 3 Ps. The first P is polyuria. High glucose concentrations act as an osmotic diuretic in the kidneys, drawing massive volumes of water out, causing frequent urination. This fluid loss leads to polydipsia, where volume depletion triggers a brain thirst signal, demanding excessive water. The third P is polyphagia. The brain registers the lack of intracellular glucose and triggers a hunger signal, despite the high levels of sugar already circulating in the bloodstream. Unexplained weight loss is a hallmark of type 1, caused by the rapid breakdown of fat and muscle tissue for emergency energy. Poor cellular nutrition causes chronic fatigue, leads to blurred vision, and significantly slows wound healing. Prolonged vascular damage results in peripheral neuropathy, characterized by numbness and tingling in the extremities. The 3 Ps are the mechanical consequences of the body attempting to manage toxic blood glucose levels while starving at the cellular level. Confirming this condition requires precise diagnostic measurements. We must analyze a blood sample to determine the exact concentration of circulating glucose. This diagnostic dashboard shows the confirmed thresholds for diabetes, a fasting blood glucose of 126 or higher, or a random reading of at least 200. Long-term control is measured via HbA1c, where a value of 6.5% or higher indicates sustained hyperglycemia over the preceding 3 months. Urine tests provide further clarity. While glycosuria indicates sugar spillage, ketonuria specifically identifies the lipid breakdown pathway of type 1. We can map pharmacological interventions directly to these cellular failures. In type 1, where endogenous production is absent, injected exogenous insulin acts as a direct replacement, binding to receptors to successfully restore the transport of glucose into the cytoplasm. Management for type 2 targets insulin resistance. Metformin, the first-line oral drug, improves receptor sensitivity and reduces the liver's glucose production, while the struggling pancreas attempts to keep up. Adjunctive therapies like sulfonylureas stimulate the pancreas to increase insulin secretion, while DPP-4 and SGLT2 inhibitors manage glucose through alternative pathways. Success in treatment depends on matching the drug's mechanism of action to the specific cellular etiology of the disease. Managing the disease requires a move from chemistry to the daily clinical oversight of the patient. Non-pharmacological management includes strict diet control and lifestyle modifications. For type 2, regular exercise and weight reduction directly improve receptor sensitivity. Nursing management focuses on continuous glucose monitoring, tracking vital signs, and strict intake and output assessment to identify osmotic imbalances. Pharmacological intervention carries the immediate risk of hypoglycemia. If blood sugar drops dangerously low due to medication, immediate administration of oral or intravenous glucose is required. Patient education is the primary defense against such events. Patients must be trained in self-monitoring and safe insulin administration. Meticulous skin and foot care are required to prevent infections that can arise from impaired healing and neuropathy. Psychological support is also necessary to help patients adhere to a demanding, lifelong treatment regimen. While diabetes mellitus is incurable, understanding its distinct pathophysiological pathways allows for targeted treatments that effectively control the disease and prevent complications.